always get, when I start answering questions around that, and Kate's there, I have my own unhelpful thoughts. I'm not sure I'm talking about this in the right way.
Well, I also think just in terms of, mindfulness is playing a bigger and bigger role in adult anxiety disorder interventions. I haven't seen it kind of picking up the same momentum in children's anxiety disorder interventions, but like interventions for generalized anxiety disorder, for panic control therapy. It's becoming sort of, I think it's always been there, this idea that you would be 100% mindful of whatever you're exposing yourself to, whatever that feared situation is. But I think in the adult literature, I'm seeing it really kind of using that label and having more prominence, and then there's more interventions like mindfulness-based cognitive therapy for adults. I have not seen this sort of pattern with kids, and I don't know if there's I think that has just more to do with the players involved as opposed to the principals not applying.
Right, because I know that they're starting to do some work and just going into entire classrooms and doing it, so not on a pathology basis, not on a targeted basis, but just starting to work with even very, very young kids, like kindergarten age.
I think there's some things like the mindfulness, there's also motivational strategies. There's some of these ideas, I think that they're kind of getting seeded into some of these other interventions, and the jury's still out right now, I think, as far as we're concerned. Just as the data comes, we're kind of tracking it and we'll be incorporating.
And mindfulness is a skill, not an evidence-based package. So mindfulness can be put into some of these things as a supplement. And I'm going to, go ahead, yeah. Then I'm going to move on and let us practice doing some of this.
I think mindfulness, according to my knowledge, it fits to the part of applying the, like you talk about thought and feeling when the child exposure to the trigger, so they are aware of, okay, I have palpitation, I have sweating, or I had been educated, that is because I'm thinking about this. So I think this is the part that can be combined into that.
Right, I think you're exactly right. That's a great example of how we use it with kids. So one of the things we wanted to do is to look at some of the sources that we have for data to make decisions about mental health. So these are some of the ones that are out there. The child welfare system used to use the child behavior checklist a lot. They just moved to the last one, which is the pediatric symptom checklist. So what I want to do is just do one quick practice, because part of changing new behavior, not just in therapy but in everything that we do, is trying it first. So I'm going to skip to the pediatric symptom checklist 17 because that's probably one of my favorites. And it's really being used in child welfare now. It's free. You can Google PSC 17 online. You can pull it off. It's easy to score. 17 items. Who likes that? Right? Versus 104. Great psychometric properties. So let's pretend that this is a kid. This is the pediatric symptom checklist that the caregiver filled out. This is a kid who's 11. Is this kid an internalizer or an externalizer? Why don't you look at the scores, and here's the information on the cutoffs. How would you categorize this kid?
Can you guys read it okay?
Is this kid an internalizer, an externalizer, or a kid with attention problems? Internalizer. Exactly. Nice. Okay, so this is an 11-year-old with internalizing. What would be one of the keys that we would look for in terms of treatment for this kid? What do we want the therapist to be doing? Working with only the caregiver, only the kid, or a little of both? Both, exactly, right. And what should the therapist be focusing on with the internalizing difficulties?
Getting the child to talk about their anxieties.
Getting them to talk about it, connect thoughts, feelings, and behavior. And then since this is a kid who looks more sad than maybe worried, what's the behavioral piece for treatment here? What do we want the therapist to be working with the caregiver to get the kid to be doing?
Activation.
Behavioral activation, exactly. So does this make sense? And this one is easy to get. I want to do one more and then we'll have to wrap up. But so for the CBCL, anything that says clinically significant means it's a big problem. Anything that says borderline means it's maybe a problem and needs watching. This is an example from a report we get on kids in foster care. Every kid that comes in foster care gets this. That's Carrie.
Used to get
we
this.
used to get this, now we have a new one. But, okay, so this is Jose, he's 7. What is Jose's main problem here? How would you categorize Jose? Externalizing. So his biggest box is externalizing. He sort of also has a difficulty where? Attention. So he's borderline at attention. Sometimes kids fit more than one box, right? Especially kids in foster care, they're more likely to fit sometimes all 3. What would be a good fit for Jose, who's 7? Go back. In terms of treatment. So, first of all, who needs to be involved in Jose's treatment? Jose, his mom, or both?
The caregiver.
Mainly the caregiver, exactly. And Jose's 7, so let's look at the young kid ones. What do you think? All of you know Jose. But basically, you can pick from anything here. And you actually might pick less on Jose's qualities than his caregiver. Is this a caregiver who might like the coaching and needs the intensive support that Sue mentioned? Is this a caregiver who really might feel supported being in a group intervention? So she's not the only parent, or he's not the only foster parent, but they have a group to work on these issues with that can feel very supportive. Or is this a parent who might like this more consultative approach that Triple P offers? And so that's how you make the selection, because all of them would be appropriate. So we have to stop right now, but we probably can take one question. Our hour gets eaten quickly with the...
I think the only other thing I wanted to mention as well is sometimes we get conflicting reports on these measures between the parent report or the caregiver report and what the child is reporting. And so again, this doesn't, isn't the total answer, but just kind of a general rule of thumb. We tend to pay a little closer attention to parent reports for acting out behaviors and a little closer attention to child reports for the internalizing behavior. So if you had to kind of weight conflicting information, we tend to bias it that way because kids are less likely to say, oh yeah, I'm out beating up my sister or doing drugs or doing whatever, and kind of admitting to those things in general, whereas those are things that parents can often observe and they can report. But kids also, sometimes the ones that are internally or secretly struggling, they may not let on to caregivers what they're going through. And so it's harder for them to necessarily know. So anyway, just kind of in the balance of things, again, you take on a case-by-case basis, but